Reproductive Pharmacology. All right, once again, for all pharmacology sections, I'm telling you to point you to our sketchy videos. Sketchy videos is the most important thing that you can do. Put it in your Anki and then hammer it out every single day. Every pharmacology video, watch it, put it in Anki, and then you'll be golden. Now, for this pharmacology video, once again, I'm just going to go over the high yield things that you must know. First and foremost, we have our GnRH analogs, okay? Leuprolide is the main one, and then everything else that ends in relin are also GnRH analogs. Now, depending on how you provide it, it's going to have antagonist or agonist effects. If you give it in a pulsatile fashion, it's going to have agonistic effects, okay? So it's going to lead to increase in fertility, right? Increased GnRH in a pulsatile fashion is going to give increased FSH and LH levels and then increased estrogen. Now, if you give it in a consistent fashion, then you're going to have an initial increase in FSH and LH because our body just thinks that it's a pulsatile fashion. But as it continuously goes on, then you're going to have a decrease in FSH, LH, and an overall decrease in estrogen, leading to a decrease in fertility, okay? So keep that in the back of your mind. No matter what, when you start a GnRH analog, you're going to have agonistic effects. But if it's continuous, then later on it will drop off and turn into an antagonist effect. And that's very key, and we'll talk about that for one of the reasons, specifically the clinical usage is for prostate cancer. We could give patients GnRH analogs, specifically continuous GnRH analogs, okay, so that can have an antagonist effect, but we have to give patients a medication known as flutamide, all right? Anything that ends in lutamide, specifically flutamide is the main one, you have to give it to patients that are also being treated with prostate cancer, okay, that are taking GnRH analogs. And the reason behind this is because when I said that we give GnRH analogs continuously for prostate cancer, right, in order to have an overall decrease in LH and FSH, that initial response to the GnRH analog is going to be an agonist response, not an antagonist response. So the patient can get gynecomastia. So to avoid that adverse effect of the GnRH analog, we have to give them flutamides as well. All right, and that's going to competitively inhibit the androgen receptor so that we're not going to have problems with our initial dosage of the GnRH analog. Okay, so let me walk through this slower. We originally, for prostate cancer, the two drugs you have to give them a GnRH analog continuously, okay? And the hope for that is so that it can act in an antagonist mechanism, an antagonist way at the prostate to stop the growth of the prostate. But the initial effect of our GnRH analog is actually an agonistic effect, not an antagonistic effect, which is opposite for what we want for prostate. And that can lead to the adverse effect of gynecomastia in patients. Now, doctors try to avoid this adverse effect of gyno by also prescribing flutamide. Flutamide is going to block the androgen receptor, competitively inhibit the androgen receptor, so that we no longer have to worry about the initial agonistic effect of the GnRH analog. I hope that makes sense. That's very high yield. They love to question you on it. So for prostate cancer, you have to give both GnRH analogs like leuprolide or anything that ends in relin. But when you give them that continuously, you have to worry about the initial effect that's agonistic that can lead to gynecomastia. And to block that adverse effect, you have to give them flutamide, which is a competitive inhibitor of the androgen receptor. Okay? There we go. Perfect. Moving on to the SERMs, selective estrogen receptor modulators. First off, we have clomiphene. Clomiphene is an antagonist at the estrogen receptor in the hypothalamus. So what does that mean? That means we're going to block all of the estrogen receptors that are in the hypothalamus. So that's going to prevent the normal feedback inhibition. The negative feedback loop is going to be blocked. So that leads to an increase in release of LH and FSH because the body, or essentially the hypothalamus, doesn't sense that there's any estrogen because we're blocking it with clomiphene. So that negative feedback loop is no longer there because we're blocking it, and that leads to an increase in production of LH and FSH, all right, which stimulates ovulation. This can be used to treat infertility due to anovulation like PCOS, okay? Next, SERM is tamoxifen. Tamoxifen, once again, is an antagonist at the breast, and it's very good antagonist at the breast. That's why we use it for breast cancer. But the issue is it's a partial agonist at the uterus and at the bone, okay? The bone is fine, right? So it's helpful for patients that have breast cancer that are past menopause because, once again, they can have increased risk for osteoporosis. So having an agonistic effect on the bone doesn't really matter. But an agonistic effect on the uterus is a problem because it increases your risk of endometrial hyperplasia and endometrial cancer later on. So if you see a patient that's taking tamoxifen and they're having endometrial bleeding and they're postmenopausal, you have to immediately stop tamoxifen. You can see polyp formation as well, which is very, very high yield and indicates tamoxifen usage for endometrial cancer, okay? So be careful. Tamoxifen is scary for endometrial hyperplasia and cancer. Tamoxifen is also used for gyno in patients with any type of prostate cancer, okay? Relatively lower yield, but keep that in mind that it can be used for gynecomastia in patients with prostate cancer because, once again, it's antagonist of estrogen receptors at the breast, right? Lastly, of the SERMs is raloxifene. Raloxifene is an antagonist at the breast and at the uterus. but it's an agonist at the bone. So it's only agonist at the bone. So this is going to be helpful for patients that are postmenopausal and are struggling with osteoporosis. And we don't have to worry about any increased risk of endometrial cancer, okay? Because it's an antagonist at the breast, all right? But it's only an agonist at the bone, so it's going to help build that bone. That's all for our SERMs. Next is our aromatase inhibitors. Aromatase inhibitors, you have to memorize the names: anastrozole, letrozole, and exemestane. Exemestane is like one of the ones that they always talk about, as well as anastrozole. So keep in mind what they do. Aromatase inhibitors in general are going to inhibit aromatase. What do aromatase do? Aromatase changes our androgens into our estrogens in the peripheral tissue, whether it's adipose tissue or whether it's in the ovaries or the placenta, right? So we're going to block the production of estrogen. So we see an overall decrease in estrogen by blocking aromatase, which leads to an increase in FSH. Now, that increase in FSH and LH can lead to an increase in ovulation, right? So we have to remember, consistent levels of estrogen is actually bad for fertility because we need to have that normal cycle of estrogen in order to have the LH surge and ovulation to occur. But in patients, once again, that have obesity, they have increased levels of estrogen just floating around consistently because of the adipose tissue that has aromatase. And that's bad for fertility. So in order to stop this, we can give aromatase inhibitors, which drops the levels of estrogen, frees up that negative feedback, and leads to an increase in FSH and LH, and then we can get back into that cycle of ovulation. So aromatase inhibitors can be used for infertility patients, okay? Very important. Specifically, letrozole and other aromatase inhibitors can be used in PCOS patients for infertility, right? With that same mechanism of action. It drops the estrogen's negative feedback that's normally at like consistent levels for obese patients or PCOS patients, and it leads to an overall rise in LH and FSH, and then it kick-starts the whole entire process for fertility. It's confusing, but it's important. Next is progestins. Progestins are just going to end in like progesterone, or like it will sound like progesterone, like gestrol, stuff like that. They bind progesterone receptors and they lead to decreased growth and increased vascularization of the endometrium, and they thicken the cervical mucus. Really low yield. They're just contraception pills. Next, we'll be discussing antiprogestins. Antiprogestins are mifepristone. Mifepristone, all it does is a competitive inhibitor of progestins at the progesterone receptor. Okay? The clinical usage for this is going to be termination of pregnancies. Termination of pregnancy, you use mifepristone, once again, which is an antagonist at the progesterone receptor, with misoprostol. Misoprostol is a PGE1 agonist, a prostaglandin E1 agonist. When you use them together, that is used to terminate pregnancy. So you have to know those two mechanisms of action of mifepristol as well as misoprostol. Okay, so mifepristone and misoprostol. The way that I remember it is OWN, mifepristone, is with progesterone. So OWN and OWN are together, all right? So remember those mechanisms of action. Next is combined contraception. So this is our OCPs. The main mechanism of action is that it stops the GnRH cycle, okay? So estrogen progesterones inhibit LH and FSH, and it prevents estrogen surge. That's the main mechanism of action and how it stops pregnancy. But other ways that it can stop pregnancy is by increasing cervical mucus viscosity. But once again, the main mechanism of action of these is to decrease GnRH release, which leads to the decrease in fertility, all right? The contraindications with this is a patient that has migraine with like auras or visual disturbances. That leads to a contraindication for combined contraception because it causes an increased risk of ischemic stroke. So be aware of the type of headache that the patient has before you prescribe them an OCP. All right. Moving forward to danazol. Danazol is just a partial agonist at the androgen site, relatively lower yield. Next is testosterone. Testosterone is an agonist at the androgen receptor. Remember, for exogenous androgen usage, you have to remember that it increases hematocrit, leading to an increased risk of thromboembolic events. It causes acne, testicular atrophy, gynecomastia, and an increase in LDL with a decrease in HDL. It leads to aggressive behavior. And remember to keep in mind that this is going to be like a patient that presents, they are a younger male, and they could be mainly like a gym instructor, okay, or a weightlifter. So they'll always say that. Next is our anti-androgens. All right. So usually this is going to be 17 alpha hydroxylase inhibition is really, really important for prostate cancers. So this is going to be helping us deal with prostate cancer as well as BPH. So first and foremost, let's start with finasteride. We already discussed it. Finasteride is a 5-alpha reductase inhibitor. Now, I used to always confuse it with flutamide, as we'll talk about in the next one. But finasteride, the way that I remember it's a 5-alpha reductase inhibitor, is the way I write finasteride is I write FIN alpha 5, TERIDE. So I use the AS as alpha 5, and that's what reminds me of 5-alpha reductase. And fin means like end in like French or some random language, I forget. But finasteride, that's how I remember finasteride is 5-alpha reductase inhibitor, okay? And so this is used to treat BPH, okay? And it can cause decrease in libido and decrease erectile function, right? But this is used for BPH, okay? And specifically in BPH, it's used for epithelium of the prostate. Next is flutamide or any lutamides. These are competitive inhibitors of the androgen receptor. Remember, once again, it's used for prostate cancer patients that are also taking GnRH analogs like lutamides or leuprolide, okay? So patients that are taking leuprolide or Relins, they have to take a flutamide as well for prostate cancer. And what they're going to do is just competitively inhibit at the androgen receptor, which leads to an overall decrease in gynecomastia, okay? Next is kinaconazole. It's just 17-alpha hydroxylase inhibitor, and it's used for prostate cancer. And lastly, spironolactone. Spironolactone is going to block the androgen receptor and 17-alpha hydroxylase inhibitor, and its clinical uses for PCOS. We can see it also for other endocrine things that we can use, but the adverse effects is gyno, which is something they really want you to know. Last but not least is tamsulosin. Tamsulosin is an alpha-1 antagonist selective, all right? But it does not decrease blood pressure. So majority of our alpha-1 antagonists cause orthostatic hypotension, but tamsulosin does not decrease blood pressure. So if you have a hypotensive patient and you want to give them some type of alpha-1 antagonist, specifically for the BPH, you could give them tamsulosin because it does not decrease their blood pressure. That's all. Once again, that was a quick high-yield summary of the pharmacology. I would 1000% recommend watching your sketchy videos and putting it into your Anki for full understanding of what you need to know for the pharmacology section.